Good afternoon, good morning, and good evening from wherever you're joining us. Welcome everyone to this webinar. My name is Efi Vallena. I'm a professor of bioethics at ETH in Zurich, and I have the privilege of, and the pleasure, of course, of chairing this webinar today. Now, you've joined us today to discuss and revisit mandatory vaccination for COVID-19 we're looking at the evidence and we're looking at the ethics for this justification. Since the summer of 2021, a few months after vaccination campaigns were rolled out in many countries, not only did we have discussion and debate about vaccination mandates, but we also saw several countries introducing them. Amongst the first countries in Europe to introduce mandates for healthcare workers was Italy and Greece, followed by other European countries. But we also saw expansion of mandates to the broader population, including perhaps the broadest mandate, at least by announcement, introduced by Austria effective February 3rd this month. Now, meanwhile, we have seen strong opposition to these mandates, but also significantly different positions being argued by national ethics commissions, scholars, and even courts. We have also seen opposition to these mandates in the form most recently of the Canadian trackers. We are all probably seen that, but also with demonstrations in many parts of the world. As the virus evolves, as our tools against it evolve, but also as we've learned from policies that have been already implemented, I think it's important to take stock of what happened so far and ask the vaccine mandate question anew. It's not that we had settled the question, it's just that we have now more experience and we are at a different phase of this pandemic. So the question is, are the mandates ethically justified? Based on what we know today and on where we are in the COVID-19 pandemic. Now, this is a big topic and a big discussion that we're going to have, an important one, and I think a very timely one. And for that sensitive and challenging topic, we have here a stellar panel with 3 distinguished participants. Today, we're joined by Dr. Zig Emanuel, Dr. Christiane Drummel, and Mr. Alan Achesa-Maleche. I'll briefly introduce our panelists, and then we'll hear from them before we going on to the discussion. I'll come back to a few housekeeping issues, but first of all, our panelists. So our first panelist is Dr. Zig Emanuel. Dr. Emanuel is Vice Provost for Global Initiatives, the Diane Levy and Robert Levy University Professor, and co-director of the Health Transformation Institute at the University of Pennsylvania. Dr. Emanuel serves as Special Advisor for Health Policy to the Director of the Office of Management and Budget in the White House, and prior to that, he was Chair of the Department of Bioethics at NIH. Dr. Emanuel has written and published widely, 15 books and several scientific articles, and he's a regular guest on CNN, MSNBC, and many other channels, and publishes often in the New York Times, the Atlantic, the Washington Post, and of course, you've heard him in various occasions, and it'll be fantastic to hear his view on the question of the mandates. Our next panelist is Dr. Christiane Drummel. Dr. Drummel is holding the UNESCO Chair of Bioethics at the Medical University of Vienna and serves as Director of the Collections and History of Medicine of the Medical University of Vienna. In 2007, she was appointed president of the Austrian National Bioethics Commission, and she's also a member of the Medical Council of the Republic of Austria. And she serves on the Scientific Council of the Agence Nationale de Sécurité du Médicament and des Produits de la Santé in France. Previously, she was Vice Rector for Clinical Affairs at the Medical University of Vienna from 2011 to 15, and Dr. Drummel was the Managing Director of the Ethics Committee at the same university. From 2008 to 15, she was also a member of the UNESCO International Bioethics Committee. And our third panelist is Mr. Alan Achesa-Maleche, who is a human rights lawyer and is currently the board member of the Developing Countries NGO delegation to the board of the Global Fund to fight AIDS, tuberculosis, and malaria. He's also executive director of the award-winning human rights organization, the Kenya Legal and Ethical Issues Network on HIV and AIDS, known as KELIN. In 2016, he was named Kenya's Pro Bono Lawyer of the Year. And in the same year, he was listed as one of the top 40 under 40 men in Kenya's Business Daily. In 2018, he was honored as the 4th recipient of the prestigious Elizabeth Taylor Human Rights Award during the 22nd International AIDS Conference in Amsterdam. So 3 excellent panelists to discuss our question. Now, very briefly, some housekeeping matters here. After our speakers, who will have about up to 10 minutes each, we'll move to the discussion. I'm going to share a slide here for the housekeeping, so I'm making sure that we're all clear on what we have to do. There we go. So if you could see this, first of all, this webinar is being recorded and will be shared on the Global Health Network platform. If you'd like to introduce yourself, and we're seeing in the chat many people have done that, or any technical issues, please use the chat. But if you have questions that we'll discuss after our panelists complete their introductory presentations, please use the Q&A box to post the questions and the topics. I'll be monitoring this Q&A box, but also please like the questions so they can come up, the ones that they really all feel that they're very important, they can come up. The organizers have muted you all and have disabled your microphones and cameras, but if you like to speak, if through the question, one of you wants to speak, I will invite you and enable your microphone, but please raise your hand for that so I can see it. And finally, if for any technical issues, you can use the chat or message there the Global Health Network team, who would be happy to help you. So now, in the interest of time, I will just invite our first, I won't speak any longer, and I'll invite our first panelist, Dr. Emmanuel. I can see Zig here, and please, Dr. Emmanuel, you have up to 10 minutes for your introductory remarks. Thank you.
Well, it's a great pleasure to be here and an honor to talk to all of you. I will try to be quick so we can get to questions, because I think it's very important to hear people's specific concerns about mandates. So let me begin with, I think the basic question is, why do we even use mandates? Why have a mandate? Why have a requirement? Why would a government ask people to do something not voluntarily, but require them to do it? I think we need to go to the heart of things. The first is that we typically have mandates when there are valid and valuable social goals that we cannot achieve by asking people to do them voluntarily. And when we can't get voluntary compliance, we resort to mandates to get enough people to do something. We should be quite clear. We need a valid, justifiable social goal, and we need other mechanisms to have been either tried or to be sure that they will not be effective in achieving that valid social goal. We in society use mandates for many, many things, and we should not deviate or forget that. We use them, for example, for getting a driver's license to drive. You're required to have a driving license. You're required to have a car inspected. You're required in many countries to use a seatbelt or to wear a helmet if you're riding a motor scooter. If you're a doctor, you're required to take some tests to certify yourself because we think that's important to assure people of the quality of your care. So mandates are pervasive. I like to point out that even when we have very, very desirable social goals, we often have to resort to mandates to get and realize those goals. In the United States, I use the argument that, we've gone to war, extremely popular wars where people think the war is valid and justifiable. Nonetheless, we have to have a draft to get enough people and soldiers to fight or to do other activities related to the war. A draft is a kind of mandate. So I think the why is a valid, valuable social goal that we're not going to achieve by voluntary mechanisms is the main justification for it. Now, what would we consider valid and valuable social goal that we would consider a mandate? It needs to be important protection of a person that they might not otherwise do. A driver's license, wearing a seatbelt, and it could be a valuable social communal goal that needs a certain number of people to do it. Otherwise, we cannot realize the goal. For example, everyone driving on the right or the left side of the street in a country, if we just allow people to go where they want, chaos and harm would result. So I think those tend to be the benefits that we end up seeing. Either they benefit the individual and the individual might not consistently do it, or might not realize how much benefit they'll achieve, or might be feel inconvenient, or there's a larger social goal that can only be achieved when everyone is doing the same activity. Now, it seems to me that we have those requirements and have had those requirements for a very long time in the case of vaccines for COVID. We have a valuable and valid social goal, keeping people not sick, or if they do get sick, minimizing the harm that they will experience through hospitalization and or death. In addition, we have a valuable social goal that if people are sick and people are hospitalized, depending upon the role they play in society, other people, the whole society, in fact, may be adversely affected because of illness. So, for example, if too many healthcare workers are ill, that can turn out to be a problem because we can't deliver care. If too many teachers are sick, that will be a problem because we can't educate our children. And those are valid and very important social goals. There can be many workers. I think a mandate in the case of COVID is valid, even if it doesn't reduce transmission, but it actually prevents hospitalization and death. And we know that it's extremely effective in preventing hospitalization and death. I think the data from the United States suggests that compared to that an unvaccinated person is 97 times more likely to be hospitalized or die compared to a vaccinated person. And for a vaccinated person, we can reduce their risk of death by something to something like 1 in 34,000 with a vaccination and a 3-dose vaccination regime. Now, I just want to end with two extremely common objections to the notion of a mandate for a COVID vaccine. Well, before I do that, sorry, I want to raise the issue that vaccinations, requiring vaccinations, mandating vaccinations is not new. It is not somehow something we haven't done before. In many, many countries, children are required to be vaccinated against many illnesses, whether it's diphtheria, tetanus, pertussis, it's measles, mumps, rubella, some places it's chickenpox. These vaccines are meant because they protect children and they protect the larger society by reducing the spread or transmission in some cases, but not in all cases. In many cases, they're meant to simply protect the child from serious illness or death in some cases. Now, certainly in the United States, we don't mandate an influenza vaccine. The result is voluntarily, we get just a few children vaccinated, 2/3 of the children, around 67% per year, and less than half of the adults, about 45% of adults get vaccinated per year when it's voluntary. And we know that's insufficient. And one of the consequences is we get in any year in the United States between 30,000 and 70,000 deaths. And that likely would go down substantially if we had mandatory vaccinations of people. I have to say, I've written and urged that I think mandatory vaccinations is probably a good thing because we would save 10, 20, 30,000 lives. That seems to me a low price to pay for of mandating a vaccine for that. Let me confront two common objections. One is somehow that requiring a vaccine is a violation of individual liberty. And this, I think you commonly hear in countries. It's my body, my right. Now, remember, it is your body, whoever you are, but the notion that you can do whatever you want, even if it endangers the health, liberty, the possessions, the peace of others, is not true. That is not something that we hold. We grant individual liberties, but everyone recognizes individual liberties are not unlimited. If we go back to, you probably can't see this, John Locke's second treatise, which has informed much of the thinking about liberty that we have, why we have society. In chapter 2 of the second treatise, John Locke makes quite clear that you need to distinguish a state of liberty from a state of licentiousness. A state of licentiousness where everyone can do whatever they want, including endanger the life, health, liberty, and possessions of other people, is what exists in a state of nature. When there's no governing, there's no rules between us, that we're free to threaten the well-being of others. Liberty is an ordered system. It's a system in society where we have restrictions. We cannot, as he says, no one ought to harm another in his life, health, liberty, or possessions. For men being all the workmanship of one omnipotent and infinitely wise maker, all servants of one sovereign master, sent into the world by his order and about his business. Okay, that's his view. And that's the view that we have come to accept, I think, that doing whatever you want is not liberty, it's licentiousness. We don't use that word much now, but that's the origins of our thinking. Liberty is an ordered arrangement where people have limits on what they can do, what they want to do, so that others can live, be safe in their possessions, be safe in their health. And it's quite critical that restricting people or allowing people to have liberty, to get a vaccine, is not restricting their liberty. And let me conclude with one other thing. It is commonly said that this is coercive, that requiring people to get a vaccine is coercive. That is simply false, because coercion means no matter what you choose, A or B, you are worse off. In the case of a vaccine that reduces your mortality to 1 in 34,000, makes you 97 times better than an unvaccinated person in terms of a risk of hospitalization and death, that is not making you worse off. So the option of getting a vaccine is not coercive compared to the option of potentially dying. And that, it seems to me, is very powerful argument that what we have here is not a coercive regime if we mandate or require vaccination, that it's perfectly compatible with liberty. Thank you.
Thank you very much, Zeke, and thank you for keeping the time. We'll move next to our next panelist, Dr. Christiane Druml. Christiane, the virtual floor is yours, and please up to 10 minutes. Thank you.
So thank you very much. I'm very pleased to, it's working. I'm very pleased to speak here and to see you all. I hope you can hear me well. And I would like to start with saying that a pandemic is no private matter. And after having heard what Seke said, I will change the words I prepared, and I will begin from a complete different side. The Bioethic Committee in Austria was asked in the year 2014 to discuss from an ethical point of view the situation of measles, because at that time there was a big number of children not vaccinated at all against those measles. And we were really pioneering in a certain way, because at that time mandates, vaccines was not really an ethical topic in German-speaking countries. Well, we have discussed it for quite some time, and in the year 2015, we said that there should be a mandatory vaccination for health workers to protect the people who are entrusted to them and not infect them with measles. And we were saying that there is one formula, and this formula you can take for whatever other disease in order to figure out what the justification of a general statutory vaccination obligation is. And it is, in other words than Seke said, the decisive factor for the vaccination obligation is the proportionality. This is something we also use to discuss human rights and intrusions in human rights. The more harmless the intervention is for the individual, and just a jab is usually a harmless intervention, especially when the vaccinations are licensed by the state or by the region. The more dangerous the disease is for the health of the population. And one can say, especially for measles, that it is a dangerous disease. And also we know that COVID-19 might be a very dangerous disease for some people, but at least, and the greater the benefit of the vaccinations overall for the public, the more justified the intervention is in the physical integrity of the individual. And so this is the formula with which you can argue why you could make a vaccine mandatory. And now those were the measles, but now we have Corona, and we were already discussing the situation of should there be a mandatory vaccine before the vaccines were even existing for all of us. And we have really lived through a very complicated and difficult time, because in the last November 2020, it was the first time that we were discussing as Bioethic Commission the prioritization of persons who should get, when there is a scarcity of the vaccine, who should be vaccinated first. And we said at that time, help the helpers. We want the health care personnel be vaccinated first, be protected first, because they have the responsibility for the people entrusted to them. And today we could say that, of course, those who get a vaccination first, who are prioritized, they should also be more responsible, and they should also have a professional obligation to be protected themselves, as not to become sick, but also to protect all the others who cannot be vaccinated because they have an allergy, or they just cannot get vaccinated due to health reasons, but also to protect all the people around them. So this is an important situation. Now, in regard to measles, many people might say, well, the measles vaccine is an old vaccine, is a vaccine we know very well, and we know how good it works. And COVID-19 is very new. But we know that it has been applied to, I think now, 7 billion people or even more. So we know quite a lot about this vaccine. And we know that it has a certain efficacy of preventing transmission, of reducing the risk for severe disease, of hospitalization and death. But we always depend in regard to obligations to the publications, the scientific publications in peer-reviewed journal. And we still learn more and more and more about this vaccine, especially as we go through the different variations and mutants of the coronavirus. But we still know that the risk-benefit ratio is good. We know that the vaccine works well. And we can see that science has worked wonderfully, as we have not had any vaccine against HIV, but we have in a very short time a vaccine against COVID-19, because all the money was really put together, all the governments helped together. And this is why we have received this vaccine so quickly. And it's not that many things were overlooked and were done in a sloppy way. No, it was really done well. And we know that the vaccine works well. And now people might say, oh, we have the Omicron variant, and it's maybe a game changer. Maybe now the pandemic will be over. But it might not be, and it might be that in the next cold season after the summer, that we might have a mutant which is as infectious as Omicron, but as severe as Delta. So we need a basic immunity of the population, and we can only receive this immunity in our countries where the rates of vaccination are not 90%, but much lower, when we have maybe a mandatory vaccine, because we need to protect the whole population. And we have done everything, at least in Austria, to invite people to get their free vaccine. We have vaccinated even in the cathedral, even at the president's office, even in clubs and so on. But still, at the moment, it doesn't seem to get higher. But we all know that we must get a vaccine everywhere in the world, not only in our country and in the neighboring countries, but we need to get it in Africa, in Asia, in South America, in Australia, everywhere, because we need to protect the whole population. And this way, with a mandatory vaccine, we might get it easier than in other ways. And so I see our moderator, which is the sign that I've spoken already too long. And I thank you for your attention. And I'm interested how this discussion will develop. Thank you.
Thank you, Christiane. No, you did not speak too long. You're just on time. So and thank you very much for keeping on time here. But let's now hear from our next panelist. So I'll invite to the virtual floor, Mr. Alan Chesa-Maleche. Alan, can I'm not seeing you. Oh, there you are.
Thank you. I'm right here.
There you are.
Thank you so much. And
the floor is yours for up to 10 minutes. Thank you.
Thank you. The danger of coming in as the last panelist is that all the talking points have been mentioned and I have to come up with new ones. So apologies if I don't flow as smoothly as everyone else. Greetings everyone from Nairobi. Happy Valentine's for those who celebrate it. And I want to approach this topic from a more practical perspective and lived experiences of what we've seen in our work as human rights lawyers who work on health and human rights issues. It's not in denial that vaccines are one of the most effective tools for protecting people against various forms of infectious diseases, be it chickenpox, be it measles, be it polio. And some of the reasons why then it becomes important is that we needed to be able to prolong the right to life and save the lives of people. But it's also not disputable that during pandemics, we don't suspend human rights. We limit human rights based on certain evidence that is brought forward to justify that particular limitation. And so the concerns that have come through indeed about vaccines mandate are largely stemming from the tension of where do I draw the line between what is for the benefit of the public and where do I draw the line with issues concerning bodily autonomy. You can have vaccine mandates in law. A parliament can pass them. A court can decide that vaccines are compulsory. A minister of health can issue a decree. President can issue a decree and say vaccines are mandatory and all citizens have to follow it. But you have to go back and question, why do you want people to take the vaccines? And in the case of COVID, you want people to take up the vaccines so that they are protected, they get less sick when they get infected, and it helps improve one immunity. Now, the question we need to ask ourselves, does mandating vaccines get us to the end goal of getting people vaccinated? There isn't enough evidence yet to demonstrate that if you have vaccine mandates, then you're able to get as many people as possible to be vaccinated, especially in the context of COVID. There may be other evidence existing for chickenpox or polio. I may not have it, but again, that's a question for discussion here. But what we are failing to take into account is what is causing, especially with regards to COVID-19, what is causing people to have hesitance to take up the vaccine. And as governments, as civil society, as UN agencies, as scientists, what are we doing to be able to address the barriers that are making people become hesitant to take up the vaccines? And the experience I've drawn from a number of countries in the global south and even in the global north, there have been concerns ranging from the availability of the vaccines. We all know that vaccines were much more easily accessible and available in the global north before they were available in the global south. Only 25% of Kenyans out of a population of over 40 million people have actually been vaccinated. We've only received 24 million vaccines, and out of this, only about 6 million people are fully vaccinated. Not because the Kenyans want to get vaccinated, but we must appreciate the inequality that took place in making vaccines available. That contributed to some of the hesitancy. Have we addressed that aspect of vaccine inequity? No, we haven't. Yet we are setting targets to say, let's get the world fully vaccinated. By the end of the year, 70% of the world should be vaccinated. We have seen challenges in terms of vaccination processes requiring you to have documentation, an ID, a passport to register into a system. What happens if you're an undocumented migrant? What happens if you don't have these documents? How then do you deal with that particular barrier? There are language barriers. Sometimes vaccination processes have not been tuned to take into account people's age, people's disability, people's social status. And this again has an effect in terms of making people become hesitant to take vaccines. There's also been lack of sufficient information and language barrier that has also made it difficult to break down information to people. A, about the importance of the vaccines, B, about the side effects of the vaccines, and 3, about what to do when you get those particular side effects. For a while before COVAX started running, we never had a clear plan around if someone had side effects, what kind of compensation would get. And so all these barriers juxtaposed with a vaccine mandate sees you meeting dangerous crossroads, because on one side, you know the good as government or why the vaccines are good, but on the other hand, there's not enough effort to be able to deal with the barriers that are causing vaccine hesitancy. And so when you drive vaccine mandates in an environment where you have not addressed the barriers, then you lose the sight of your goal, which is to get everyone vaccinated. And again, when you introduce vaccine mandates, not taking into account the existing laws and practices within a country. So how do you align your vaccine mandates to the international conventions that countries have signed? How do you align your vaccine mandates to a democratic process where people give their views, their legislators make their thoughts, and the law comes into place? Are the mandates coming in as directives where citizens have not had a chance to give their views? Again, how do you expect that uptake when there's going to be pushback in a process that people have not been fully involved in? And so that borders both on a legal issue, it borders both on a human rights issue, and it also borders on an ethical perspective that we need to deliberate and figure out how do we address this. One of the ways we have seen uptakes in vaccines is by gaining trust of the community. And the way most vaccines have been rolled out has been a top-down approach. We've learned a lot from the HIV response around why it's important to mobilize communities, why it's important to have the buy-in of communities, especially on taking of ARVs that are lifelong treatment, and how that in certain instances has addressed the fact that people have then retained taking the ARVs. At least from where I sit, I haven't seen a lot of that happening in many countries. And so that lack of trust continues to exist between the public, the Ministry of Health, and even how vaccine mandates have been enforced. And I keep asking myself the question, so what happens if someone doesn't get vaccinated? Are we going to jail everyone? Are we going to fine everyone? What exactly will be the end game? Is it better to invest more in dealing with the barriers, or invest more in dealing with the enforcement of the laws and the policies that vaccines are mandated? Of course, it's a tough balancing act, but we need to be able to know where do we draw the line between bodily autonomy and public health safety. And for you to be able to get this balancing act, you need to be able to be guided with the legal framework that is in place, and the Syracuse principles that talk about limitation of rights within a public health emergency provide this particular perspective. I'll leave these opening remarks at this particular point, but emphasize the point that yes, vaccine mandates may be the way to go if you want to be able to get people to uptake vaccines, but is it the only way? And are there ways we can invest more in community systems, invest more in building trust, invest more in providing information to meet the end goal of getting people to be vaccinated, and not forgetting, let's make vaccines and treatment for COVID available to everyone if we truly want to put this pandemic under control. If we keep the inequality, we will forever go through the cycles of variants and not everyone getting vaccinated. Back to you, Prof. Over.
Thank you so much, Alan. Thank you for your remarks, and thank everyone on the panel. Maybe we can get your videos back on so we can see you. Terrific remarks and very rich comments. And we are having, I see a lot of questions already in the chat. So
can I respond to two things from Alan?
Yes, you have two questions addressed to you, right?
No, I wanted to respond to Alan for a second.
Okay, because we have some coming up for you, but I'll sum them up. Okay, yes, please quickly to Alan, and then we
all right. Go. First of all, Alan, I can't speak for the whole world about the effectiveness of mandates. I can speak for the United States, and especially in the healthcare community, where mandates have been enormously effective. I mean, enormously effective. You get people, you start out with a healthcare system where 70% of the workers are vaccinated. You have a mandate. And as you approach the deadline, because people love deadlines, people are saying, I'm going to quit instead of getting vaccinated. And almost all the healthcare systems that have done this have reported much less than 1% of people quitting. You have New York City with a mandate for its workers, and you see the exact same thing. As you get close to the deadline, people who were willing to trade off job for not getting vaccinated suddenly say, oh, that job, it's good. And when they don't, I would submit to you, get vaccinated, it's for a job. It's because the job is not meaningful. It's not very good. It's an oppressive situation. So I would say, first of all, mandates do work and they are effective. The second thing I would say is inequality in distribution was a problem. It's been a problem for a year. That's not our problem now, especially in developing countries and lower income countries. The problem now is that people are resistant. I talked to colleagues from Ghana and other places. People at the top get vaccines, but other people just don't want vaccines. And I'm not sure, remove barriers. They're widely available. They're free. People aren't having to pay for it. It's not clear to me, and they're very safe. We've given 4 billion people on the face of this earth vaccines. I'm not sure what else, what are the other barriers. There may be an administration barrier in some countries, but it's not the money, it's not the problem. And unlike HIV and ARVs, this isn't lifetime. These are 3 shots, as far as we can tell at the moment, and that they're not very painful. So I'm not completely convinced by your argument that we've got lots and lots of barriers here about accessibility, cost, etc. We've really done an excellent job, I would say, in the world at removing those barriers.
Thank you, Zig. Okay, so maybe I'll jump in here. I had another first question, but let's go with something else. I think what Alan and others also who are asking questions here seem to say is that even if we agree that we've done, in different countries have done different things, but let's say we've done a lot of things to show that the vaccines work, that they are the best tool we have right now, it doesn't seem that they have worked to make people trust the whole thing, to trust what we put on offer. And so I think so there are different types of work here, work to prevent severe disease and hospitalization, and work to build cohesion, to build trust, and to work towards those other sides that we need in society in order to move public health forward and other social goals forward. So the question I think that we come back to is, if we have this problem of trust, which was there before, but maybe it has worsened during the pandemic, for enforcement of vaccines, actually, that do these enforcements bring us forward in terms of building more trust and achieving our social goals more broadly? So I think that's one question we need to address. I'd like to hear again from Christiane, that didn't speak now. So we had Zig, I'll go to Christiane, Alan, then go back to Zig. And then another question I'd like to put to you all is this notion of proportionality. Christiane mentioned proportionality. In our ethical justification, we use proportionality, right? Is the measure proportional to the problem? And here there are 2 levels of proportionality, and I think they're coming through the questions we have in the chat. One is if the intervention is proportional to the problem that we're going to solve. The other is the way we intervene and what does it really mean to have a mandate vis-a-vis the job loss, education access, getting to a restaurant or going to the theater. So proportionality operates in these 2 levels, and I would like your thoughts on that kind of thing. So first question, does it work with trust? What can we do about that? And second, how do we see proportionality playing out at these 2 layers? Christiane, can I start with you?
Yes, thank you very much. I think this is a very important question, because we all are faced in our countries with people who are having, who are believing in fake news, who are having, how do you say, who think that there are some stories behind the craziest things. And I guess that when the states are not able to fight against this lack of competency, of this parallel world where all these people are, it will be very difficult, not only for health and vaccination, but for everything. So the states really do have a moral obligation and a democratic obligation to fight against all these paranoid and other beliefs. Even Empress Maria Theresia in Austria in the 18th century, she sent out a doctor to Eastern Europe to find out why people were thinking of bats and other strange things, which is counterproductive to health. So this is nothing new, but with social media, it is really bad. And another problem is that in some of the countries, the fight against the epidemic was not only given into the hands of the Minister of Health or of the health authorities, but it was completely politicized. And this is a very bad thing, because so politics and the fight against it became one big thing, and people who were opposed to some political party, who were opposed to the government, all of a sudden were also not believing in the means of how to fight against the disease. And the third, and then I'm finished, is this voluntarily mantra. We know that we are away from paternalism, and we are, since maybe 60, 70 years ago, we are turned towards autonomy of the persons. But with vaccines, it's always, oh, you don't need to get vaccinated. It's only if you want to. It's just voluntarily. Don't do it if you don't want to. So many people think, is there something wrong with these vaccines? Why don't they tell me I should do it? Why do they stress so much that it's only voluntarily? And I think this is a bad thing. When I was in school, I just got vaccinated against all sorts of diseases, and nobody talked about it. It was just normal. And now it's a big story, and I think it gets a weight which is completely away from the real sense of keeping healthy and prophylactic. Thank you.
All right, so it seems proportionality, proportionality for you is settled then in this case, Christiane. I'll leave it, I'll go to Alan quickly. I'll come back to you on that proportionality part, but I see what you mentioned. Oops, Alan.
Thanks. So real quick on the issue of trust, I think the gateway to getting anyone to do anything in public health is to build their trust. Once someone has buy-in onto a public health, onto a medication, for any adherence, you must build trust. For you to build trust, you must provide information to ways that can reach people, to ways that they can understand them, to ways that is tailored to the needs that they need to address. Then you must address the concerns and the myths and the theories that they have for you to be able to move forward. Now, from where I sit, that hasn't happened in many countries, including where Dr. Ezekiel sits. The Black community who faced the Tuskegee scandal was some of the few that resisted the COVID vaccines. I have friends in New York, and there's a concern about uptake among the Black community of vaccines, and partly that's because of the historical injustices they may have faced. Now, if you don't address that, you don't build their trust. And so you build the trust to be able to get people to adhere. But the practice we have seen is that there's a rush to go to the mandates and say, if you don't get vaccinated, you're not going to walk into this mall, you're not going to access this. And some countries have gone to the extreme saying, you may not even get government services, you may not get a national ID, you may not get a passport. And now that is bordering on violating other rights. And so the question then becomes, what do you need to do to be able to build trust from the beginning, to be able to get people on board, to be able to agree in terms of uptaking vaccines that definitely have a health benefit for them? And I maintain the argument that unless you remove the barriers or minimize the barriers or address them, you can't win with threats and saying, we'll either jail you, you'll either lose your job or you'll either X and Y that will happen to you. That, in my view, hasn't worked well, at least in Kenya. I've seen it with the TB response. I've seen it even with people who don't take their children for vaccination. For me, as a human rights lawyer, threats have never been the end game. Even with ARVs adherence, it first began with threats, but we realized the importance of counseling, and HIV is one of the response that shows the highest amount of investment that has been made in counseling to get people to adhere, putting people in support groups, getting people to speak about it, getting people to share their experience. We must work with that patients, but in the meantime, we must make vaccines available to all people. Had we started on the same footing with all our friends in the global north, the first time they were getting their first vaccine would be the first time Kenya was getting its vaccine, we may have been seeing different response rates. And that's what we need to quickly address to continue making the vaccines available. I don't disagree that the US under Biden's administration has made efforts to make vaccines available, but a lot more could be done by other countries who have hoarded vaccines in the beginning and made it extremely difficult to get TRIPS flexibilities. Back to you.
Thank you, Alan. And absolutely, the point of access is immense. But also, what we're seeing in the northern countries where access was less of a problem, we do see this resistance and hesitancy. So yes, there is the equity of access question, and that contributes to lack of trust and to hesitancy. But also, we see in places where we have more access. I'm like taking Europe. I'll leave the US out for a second. In Europe, we had easy access to vaccines, and still in Europe we're seeing also high percentages of the population resisting the idea. So that's a different. It plays out differently. Even if access is better, we saw similar types of mistrust and hesitancy. So the question I want to go back to is there, and some of you mentioned, we tell people this, we tell people the other. Do you see a problem with how we have communicated what the vaccines are about and why we as a society we have to together do something for this pandemic? So is there a problem with how we approach the vaccines? For example, vaccines for others or vaccines for you, protecting yourself or protecting others? Does this communication or the way we communicated affected the outcome, you think? Or did we have transparency issues in case of what do we really mean? What are indicators? But going back to proportionality, at which threshold we make a decision or another one? Zeke, you've been involved with.
I want to make 3 quick points. Alan, I'm not sure I understand your argument that if the vaccines were available equally around the world, that would have gotten rid of hesitancy in Kenya and other developing countries. That doesn't seem to me to be a very strong argument that they were available in some places first. Look, I think it's unethical that they were unevenly distributed, but I don't think that they were unevenly distributed right from the start is a justification or the explanation why there's low uptake or suspicion in Kenya. I just don't understand that logic. Second point, you made the claim that there was low uptake among the minority communities in America. That actually turns out not to be true. The disparities in uptake are not black-white in America. The disparities are Republican Democratic. It's Republicans who are suspicious. That is very different. We now have uptake, if you take political control for political party between blacks and whites is consistent. We have, and that leads me to my third point. I totally agree. Trust is very important. Trust is very, very important. What has undermined trust is not the public health issue. It's not a mandate issue. What's undermined trust is Facebook, Twitter, social media in general. And that is a separate problem from a public health problem. I agree, we need to regulate them. We need not to limit free speech, but we need to get rid of these algorithms that allow people to get misinformation and just misinformation without additional information. And let me make my last point. We did a lot of community building around HIV. We did a lot of community building to get trust, right? It took 20 years. We don't have 20 years in the face of a pandemic. And I think that's a very different scenario. HIV is a terrible disease, affected many, many people, but because it's spread sexually and not spread through respiratory virus, there's a limit to its spread. And a pandemic is a very different thing, and waiting a long time to build trust through lots of community meetings and lots of discussions is, I think, a challenge that your point doesn't address. When you have an emergency, a slow process is not going to be your optimal process, I would submit to you.
All right, well, thank you, Zeke. And we have 2 minutes to go to the hour. I just want a quick round from all of you. So do you see a change about we heard justification, yes, and hesitance for mandatory vaccination. So is there a difference that you think since the pandemic began, or since we had the vaccines at this summer of 2021 and now in terms of that justification? Christiane, Alan, and Zeke, you will have the last word.
Thank you. Well, I think that many harm is already done in regard to, those fake news and this very disproportionate understanding of a pandemic, and of the understanding that a pandemic is no private matter. And because it's too much mixed with the pandemic restrictions we have. And still, it would be much easier to have everybody being vaccinated than lockdowns and other restrictions which we fear, and the restrictions of traveling and so on. So I fear that many problems are here and will not be easily to overcome. And I just hope that the virus will be not stubborn, but milder and stay the way Omicron is, and that we can come out of it. Otherwise, I don't know. But today I have a pessimistic day, and that's not a good end of an interesting talk. Let's just hope that it will be easier, and that this will be the last pandemic for a long time, and it will be over. Thank you.
Thank you, Christiane. Alan, on the change between then and now, but very briefly, we're on the hour, and then Zeke, you'll be the fastest one. All right, Alan.
I think just on the hour, I want to say vaccine mandates should be not the first option, but the last option and the least restrictive option. The approach we have seen is that governments choose to take it as the first option, and that's where they fail. And anyone who's trying to be able to ensure vaccine uptake takes good effect should work in not only building trust in the community, but providing information that would counter your Twitter, your Facebook, and your Republican algorithms, because information is critical to get to people to buy their buy-in. We're in a hurry to get rid of the pandemic, but we're not understanding what is causing people not to take the vaccines. Unless we deeply understand that, we may still have it for 20 years, God forbid. Over.
Thank you, Alan. Zeke.
Oh, I agree with Alan. I think mandates should be your last option and not your first option. And to that extent, I think removing barriers, making vaccines widely available, removing the price limits, and educating people are important. But as we've learned through extensive study of Facebook and Twitter and all, false information travels faster and better than true information. And it is a very big problem, this misinformation campaign. And we need to get our arms around it, not just for COVID, but for the sake of democracy and trust worldwide. And I think that ought to be a top priority.
Thank you, Zeke. And thank you, our panelists. Fantastic comments, an excellent discussion. I tried to sum up the many questions in some of those bigger questions that we ask our panelists. Thank you all for participating and for joining us today. It seems that we're not done with the topic, so we need another one organized on the mandates, but probably the most important one on misinformation and how we deal with the trust issues today. So thank you all very much. And we'll see you in the next episode at some point. Thank you. Bye-bye.
Thank you, Effie, Alan, and Christiane.
Thank you, everyone. Bye-bye.
Bye-bye.